Yeah, you're good.
Hi, I'm Dr. Henry. We're here to start a series of tutorials on the chiropractic treatment of sports injury. When you're using chiropractic treatment for sports injury, it's based around the neurophysiological response of proprioception that's used in the body. You're probably familiar with proprioception as the righting reflex or the balance, but it's a whole lot more than that. The sensors that surround all the joints in the body read the load put on the joints as it happens, and they instantly either approve or disapprove of the load put on the body. In other words, the sensors can tell right away whether or not the joint's able to take it, take the load, take the work, take the effort. If it's not, there's a danger signal sent up to the brain, and the brain then sends a signal back to weaken the muscles crossing the affected joint so that they don't inadvertently damage the joint further, we assume. We don't really know, we're just going by functional. All right, so we're going to show you how I initially go through and assess a patient for treatment. These treatments are done prior to the game, prior to a practice session, prior to a workout. And the treatment is done before the athlete will see the trainer or begins his warm-up. The treatment is the initial assessment and the initial readying of the patient to go ahead and do what they're going to do as far as an athlete goes. All right? I've got here one of my patients, a lady named Latika, and she's helping us out. If you would lie on your back, put your head up here and your feet down at that end. Now, our original assessment, we start out with checking the hip adductors. That is to check us for, when the hip adductors go weak, it's an indication that there's something going on wrong in the body. It could be the mid-back, low back, knees, or ankles, but it's a good general assessment. You are evaluating the effectiveness of all the target muscles from the second lumbar vertebral spinal nerve down to the second sacral nerve. Okay, with this leg straight, I want you to push out against me as strong as you can. Ready? Push hard. Very good. Hold and then relax. And then this one, push out to yours, so that's it. Hold and then relax. Okay, the fact that there's a little bit of shaking when she's effort means that there's weakness in there and she's crunching and recruiting muscles. What we now do is come up and look at the position of the skull. We're going to start from the top and work down. So what we do is palpate the occipital mastoid processes of the occipital bone. And what we want, what we expect to find, is to have those mastoid processes equal AP and rotational. All right? So we look here, and on her we find, of course, that the occiput is high on the left and rotated backward on the left, indicating, that she needs work in C1 and C5, but I know that because I treat her for it. All right. The next thing we do after that is to come down here and look at whether or not we're having an iliopsoas spasm. 2 inches from the navel and 2 inches down, and we press. If we run into a tight, painful muscle, we know that the back is also unstable and there's something that needs to be done there, because it's recruiting the iliopsoas muscles to assist in the support. And that's not supposed to happen. The iliopsoas muscles are for articulation and movement, not so much for support. But we press both sides, and the player probably won't like this. If you're going to work these, what you do, if you find these are tight, which on her they are, you're going to press down for about 15 seconds. You're not going to press hard, press to where the muscle stops you from pushing it, and just hold it there. Don't try to create any real problems like that. Okay? So, backing up here to the top, we make a correction in the neck. Okay? We make a correction in the mid part of the neck. Good. We're going to come around. You get to see my back. I'm going to work on the thoracic vertebra. What thoracic vertebra is significant? 3 and 4 and T12L1. Very important to do that one. So I use this technique to do this. Come up with a little pressure just like that. And then we move the arms down a little bit. Again, position there is the T12L1 and push down like that. Let it go. That's good. We come back up here We look at ASIS positions, rotation, A and P, and intern and outsert. Right here, she has work on this side, so we're going to lay on that side, please. Bend, looking down, and just like that. Other side, please. Okay, why don't we stop it while we flip that? Good. Great. Okay, now that we have the vertebra in more or less a stable and correct position, here's a good time to check the TMJ. How you do that is simply come off of the zygomatic arch, and the space between the zygomatic arch and the upper end of the TMJ should be almost perfectly equal side to side. If they're not, you've got some work to do. All right? We're going to go from there to the pre-performance stretch. Patient in supine position. She's going to push down with her knee against me. Push, and she's going to hold that, and you're going to hold it about 6 or 7 seconds. Relax, and then you stretch. Gluteus medius first. Gluteus maximus first. Gluteus maximus is the largest muscle in the body, and we want to stretch it first. Okay, you want to start with that. Push down on me. Push. What you're doing is challenging and recruiting muscle fiber. Relax. So that as you stretch, you get a cleaner, more encompassing stretch with the muscle as far as that's concerned. The next stretch, she's going to challenge against me. You're going to push outward with your foot. Push. Obviously, external rotators. Relax. Bend the knee toward the shoulder with the foot across. Again, hold the stretch about 15 or 20 seconds right there. You're going to do this on both sides. All right? Next stretch is going to be the TFL, ITB. TFL, gluteus maximus, ITB. She's going to pull away from me, and you're going to resist it. She's going to relax, and then you bring the stretch all the way across. We do the same for both sides. Now we're ready to look at her in a prone position. Face down, please. Okay. Let's start with the hamstrings. She's going to hold in this position, hold strong. I'm going to push. She should be able to, any athlete should be able to hold that against your pressure. She can't, it's not surprising, just relax. The other thing we're going to check is we're going to check the lateral adductors. So we're going to pull, you're going to hold, I'm going to pull to the outside. Hold. Okay, that's not too bad. I'm going to push, you hold. The way we correct this usually is an adjustment to the knee. These are Zindler's adjustments from British Columbia. We then come back and we check the hamstrings. We bring this up, hold strong, and the muscle goes strong. What did we just do? We stabilized the knee with an adjustment. We came back using applied kinesiology on the origin and insertion tendons of the hamstring muscles. You can tell which muscles are involved by palpating the back of the knee and finding the tight tendon. The tight tendon will indicate the weakened muscle, and you want to bring that muscle up strong. Once all the hamstrings come strong, the knee is stable. We can then go to the hip, where we had some weakness here. You're going to start with the piriformis and the gluteus medius, again using AK techniques. Origin insertion tendons, muscle spindle group. Just pull, bring the leg up. I'm pulling to the side, you hold strong. The strength indicates that A, the joints that we're dealing with are in place and stable, which allows the muscles to come up and go strong. All right. With the patient prone, hang on a second.
It's okay.
The end of the page. Okay, are we getting this?
Mm-hmm.
Okay, good.
I think some of this is going to only be able to be done in Zoom once we have a camera that's got a lens zoom on it.
That way, when we go up there, you'll know what camera you want to get.
Yeah.
Because I don't know shit, okay? Okay, back on?
Yep.
Okay, after we've finished hamstrings, hip muscles, we want to come down and take a look at the Achilles. We want to know before they know whether the Achilles is having a problem. what we do is we have the patient pull up with her toe and then down again. As she pulls up, you slide your thumbs up on either side of the Achilles. If you find a thickness or a roughening alongside, it indicates there's a problem with the Achilles, and you repair it in manners that we'll show you later. Okay? The last thing you want to do is you want to take the foot. She has her shoes on, but you're going to do this without shoes on. And what you're going to do is you're going to approximate the heel and the toe together, and you're looking for good movement in the arch. No movement in the arch is a problem, which you'll learn to repair. Okay, would you please lay face up again, please? Okay, now that we've done the spine, the knees, and the hips, and the Achilles, the next thing we're going to look at is other hip muscles that we need to work on. Sartorius gracilis. Take a hold of the ankle, pull out as the patient resists. Please resist. Okay. If it gives at all, it's weak. Again, we come up using AK, which is origin insertion tendons stretched long, muscle spindle group stretched long, bring it back up and test it again. When it goes strong, you know that you've done what you need to do. We're going to come down to the ankle. What you do with the patient, you ask the patient to pull their ankle up strong. You're going to push down. They're going to resist. Good. In the position like this, in the position like this, you're going to do that quickly. We don't have to go this slow. If there's a weakness in the ankle, you correct it. We'll show you that later on. All right. And then the last thing you want to look at is you want to look at the feet to make sure that the metatarsal phalangeal joints are good, that we don't have a dropped metatarsal head. All right. Stop.